Hi class, welcome to chapter 21, which is on the respiratory system. On Canvas, you can see there's three parts to this lecture. Part A is all an anatomy review. So review that part A PowerPoint on your own. You're responsible for the anatomy. Make sure you remember all the anatomy of the respiratory system. And then we'll go through parts B and C in this recording. I'll wait to see how long part B takes and see if we can get through both in one video lecture. So respiratory physiology, we're going to talk a lot about the mechanisms of breathing, the pressures that are involved. We'll also talk a lot about gas exchange. The workshop on the respiratory system about gas exchange will be really helpful if you can try to get to that workshop as well. Again, this is a reminder that you do have to complete 3 workshops to get credit. They're worth 10 points each. The MDSC will email me at the end of the semester if you've completed those workshops. So mechanisms of breathing, we talk about pulmonary ventilation consisting of 2 phases: inspiration, where gases flow into the lungs, and expiration, gases exiting the lungs. And all of this has to do with pressure relationships within the thoracic cavity. Atmospheric pressure is the pressure exerted by the air surrounding the body, and normal atmospheric pressure at sea level is 760 millimeters of mercury, and that's equal to 1 atmosphere. Respiratory pressures described are relative to atmospheric pressure. So negative respiratory pressure will be less than atmospheric pressure. Positive respiratory pressure is greater than atmospheric pressure, and 0 respiratory pressure means it's equal to atmospheric pressure. Intrapulmonary pressure then, and we abbreviate intrapulmonary pressure as that highlighted. This is the pressure within your alveoli, which are the little air sacs within the lungs. This is also called intraalveolar pressure. This will fluctuate with breathing, but it always eventually will equal the atmospheric pressure. Intrapleural pressure is the pressure in the pleural cavity where your lungs reside. This will fluctuate with breathing, and it's always a negative pressure. It is usually always 4 millimeters mercury less than the intrapulmonary pressure within the alveoli. And the fluid level must be kept at a minimum. Excess fluid is pumped out by the lymphatic system. And if fluid accumulates within the pleural cavity, this positive intrapleural pressure develops, and that is what causes a lung collapse if there's too much fluid and too much pressure within the pleural cavity. So the intrapleural pressure are the 2 inward forces promoting lung collapse. This is the lung's natural tendency to recoil, but because of elasticity, the lungs will always try to assume the smallest size. And the surface tension of the alveolar fluid is the surface tension pulling on the alveoli to try to reduce their alveolar side. Intrapleural pressure is one outward force tending to enlarge the lungs. So this is the elasticity of the chest wall, which pulls the thorax outward. And negative intrapleural pressure is affected by those opposing forces, but is maintained by strong adhesive forces between the parietal and visceral pleura. The transpulmonary pressure then is when we subtract these 2 pressures, kind of the inward and outward forces together. This is the pressure that always keeps your lung spaces open, that keeps your lungs from collapsing. So the greater transpulmonary pressure, the larger lungs will be, and the lungs will collapse if the intrapulmonary pressure is equal to the pulmonary pressure, or the intrapulmonary pressure is equal to the atmospheric pressure. So negative intrapulmonary pressure must always be maintained to keep the lungs inflating. So this is kind of confusing. This is a really good diagram explaining again where all of these pressures are relying. So here's atmospheric pressure from the outside, the transpulmonary pressure, which is the difference between 0 and -4, and then the intrapleural pressure is the pressure within the cavity. And all these pressures are required to be in sync to keep the lungs from collapsing. So here's a look at rupturing either the parietal or the visceral pleural can cause a pneumothorax, which means a pneumothorax means that air is in the pleural cavity, and this causes the intrapleural pressure to become equal to the intrapulmonary pressure, and as a result, the lungs will collapse. So again, this is some sort of wound. So if someone gets stabbed with a knife or there's some other damage to the rib cage that caused the ribs to puncture the lungs, this could cause air to enter the pleural cavity and cause the collapse of the lungs. Atelectasis is the lung collapse due to a plugged bronchiole, which causes the collapse of alveoli, or a pneumothorax, which again is when you have air in the pleural cavity. And this can occur from either a wound in the parietal pleura or rupture of the visceral pleura. It's treated by removing the air with the chest tube, and when the pleura heal, the lung will re-inflate. Pulmonary ventilation then consists of inspiration and expiration. This is the mechanical process that depends on volume changes in the thoracic cavity. These volume changes will lead to pressure changes, and the pressure changes will lead to the flow of gases to equalize the pressures. So for pulmonary ventilation, we use the relationship of Boyle's law, which is the relationship between pressure and volume. Gases will always fill the container that they're in. So if the amount of gas is the same and the container size is reduced, pressure will increase. So pressure varies inversely with the volume. So what that means, if we have a pressure and volume of one container, it will equal the pressure and volume of the other container. So what this means, if the pressure increases in a container, the volume will decrease. And if the pressure decreases in a container, the volume will increase. So that was what inversely proportion means. Inspiration is the active process involving inspiratory muscles. Your inspiratory muscles are your diaphragm and your external intercostal muscles. The diaphragm is the most important muscle in breathing. When it contracts, it moves inferiorly and flattens out. That results in increase in thoracic volume. And your intercostal muscles, when your external intercostal muscles contract, they lift up and out your rib cage, much like when the handle on a bucket is raised. And this also results in an increase in thoracic volume. So this is just a look at how the diaphragm and the external intercostal muscles will change with inspiration and expiration. As the thoracic cavity volume increases, lungs are stretched as they are pulled out with the thoracic cage. This causes the intrapulmonary pressure to drop, and because of the difference and the intrapulmonary pressure, air will be kind of pulled into the lungs. During the same period, the intrapulmonary pressure will lower, which makes it less than atmospheric pressure. Inspiration, these forced deep inspirations can occur during vigorous exercise or in people with chronic obstructive pulmonary disorder. The accessory muscles will also be activated to try to further increase the thoracic cage size to create a larger pressure gradient so more air will be inspired or drawn in. So these next couple of slides just show the changes in the thoracic volume and the sequence of events during inspiration and expiration that you guys can kind of review on your own. So what happens to the muscles and how they pull air in during inspiration. And then during expiration, quiet expiration normally is just a passive process. Your inspiratory muscles will all relax, the thoracic cavity volume will decrease, and the lungs will recoil. The volume decreases, causing an intrapulmonary pressure to increase, and then air will flow out passively. Forced expiration, when you're kind of forcing your lungs to exhale, this is an active process that uses oblique and transverse abdominal muscles as well as your internal intercostal muscles. And again, here are the sequence of events during expiration as well that you guys can review on your own. This shows the changes in the intrapulmonary and intrapleural pressures during inspiration and expiration. And you can see these changes shown here, where the intrapulmonary pressures lie, what happens with the intrapleural pressures, and then as the volume of breath changes, as you breathe in and breathe out, and what happens with those pressure changes. Non-respiratory air movements, many processes can move air into or out of the lungs besides breathing, and these may modify normal respiratory rhythm. Most result from a reflex action, although some are voluntary. So for example, coughing, sneezing, crying, laughing, hiccups, or yawns. There's three physical factors that influence the ease of air passage and the amount of energy required for ventilation: airway resistance, alveolar surface tension, and lung compliance. Airway resistance has to do with friction, which is the major non-elastic source of resistance to gas flow. It occurs in your bronchial airways. And the relationship between airflow pressure, the change in pressure, there's a little triangle, which means change, and resistance is shown here. So this just means the gas flow changes inversely with resistance. So as resistance increases in the bronchial airways, your gas flow will decrease, which makes sense. Airway resistance in the respiratory tree is usually insignificant for two reasons. The diameters of your airways in first part of the conducting zone are incredibly huge, and progressive branching of your airways all gets smaller, which leads to an increase in total cross-sectional area. So any resistance in the airways usually occurs in medium-sized bronchi, and resistance will disappear at terminal bronchioles, where the diffusion is what drives the gas movement. So this just shows the resistance in respiratory passageways. The conducting zone is where the greatest resistance will occur in the medium-sized bronchi. So if there's a blockage, it will occur there. But in the respiratory zone, there's really literally no resistance because it all has to do with surface area of the alveoli. So as airway resistance rises, breathing movements become more strenuous, and severe constriction or obstruction of the bronchioles can prevent life-sustaining ventilation or can occur during an acute asthma attack and stop ventilation altogether. Epinephrine is a hormone that will dilate the bronchioles and reduce air resistance. Alveolar surface tension then is the attraction of liquid molecules to one another at a gas-liquid interface. It tends to draw liquid molecules closer together and reduce contact with dissimilar gas molecules, and it can resist any force that tends to increase surface area. So water, which has a very high surface tension, will coat the alveolar walls in a thin film, and this tends to cause the alveoli to shrink to the smallest size or collapse. Surfactant is the body's kind of detergent-like lipid and protein complex that helps to reduce surface tension of alveolar fluid. This prevents alveolar collapse, and it's always produced by your type 2 alveolar cells. Insufficient quantity of surfactant is the premature cause in premature infants, which causes infant respiratory distress syndrome. So in premature babies, if they're born before their lungs have fully developed, this can be incredibly scary because their lungs aren't able to produce surfactant. An increased surface tension results in the collapse of these alveoli after each breath. So the alveoli must be completely reinflated. This uses a tremendous amount of energy, and it's very common in premature babies because the fetal lungs do not produce adequate amounts of surfactant until at the last 2 months of development. So the treatment is to spray natural or synthetic surfactant into newborns' air passages. The positive pressure devices also help to keep alveoli open between breaths, and severe cases may require mechanical ventilation. Survivors of mechanical ventilation may develop what we call bronchopulmonary dysplasia, which is a chronic childhood lung disease as well. And then lung compliance is our third physical factor influencing pulmonary ventilation. Lung compliance is a measure of change in the lung volume that occurs with given change in transpulmonary pressure. It's a measure of how much stretch the lung has. It's normally high because of the distensibility of the lung tissue, surfactant, which decreases alveolar surface tension, and higher lung compliance means it is easier to expand the lungs. Lung compliance will be a measure of change in lung volume that occurs with the given change in transpulmonary pressure. It's a measure of how much stretch the lung has, and it's normally high because of distensibility and surfactant, and the higher lung compliance means it's easier to expand the lungs. Lung compliance can be written mathematically, and you don't need to know that equation, but it has to do with compliance, the change in volume, and the differences in pressures. Any decrease in the natural resilience of lungs will diminish the lung compliance. So chronic inflammation or infections like tuberculosis can cause non-elastic scar tissue to replace normal lung tissue. And this is called fibrosis. And decreased production of surfactant can also impair the lung compliance. The lower the lung compliance, the more energy is needed just to breathe. Also, total compliance of the respiratory system is also influenced by compliance or distensibility of the thoracic wall, which can be decreased by deformities of the thorax, ossification of the costal cartilage, which can be very common in old age, and even paralysis of the intercostal muscles. So in order to assess ventilation, we can take several respiratory volumes, which can assess the respiratory status. These respiratory volumes can be combined to calculate respiratory capacities, which can give information on a person's respiratory status. And respiratory volumes and capacities are usually abnormal in people with pulmonary disorders. We can use a device called a spirometer. Originally it was a very cumbersome clinical tool used to measure the patient's respiratory volumes, but now it's an electronic measuring device system. So here are the respiratory volumes, which you should know. Tidal volume is the amount of air moved into and out of the lung with each breath. Normally it's about 500 milliliters. Inspiratory reserve volume is the amount of air that can be inspired forcibly beyond the tidal volume, and this is about 21 to 3,200 milliliters. The expiratory reserve volume is the amount of air that can be forcibly expelled from the lungs, and the residual volume is the amount of air that always remains in the lungs, and this is the amount of volume needed to keep the alveoli open at all times. We can combine two or more respiratory volume to get an inspiratory capacity, functional residual capacity, vital capacity, and total lung capacity, which is the sum of all of them. And this graph really does a great job of explaining all of these respiratory volumes and then the capacities when you add two or more of them together. And you should be familiar with all of these respiratory volumes and how you can kind of add them together. So, and this is just another respiratory volume and capacity, and give you kind of a brief description of each. The dead space then, so anatomical dead space does not contribute to gas exchange. It consists of air that remains in the passageways. Alveolar dead space is space occupied by non-functional alveoli, and this can be due to collapse or obstruction. And then the total dead space is the sum of anatomical and alveolar dead space. A spirometry measurement can distinguish between an obstructive pulmonary disease, such as bronchitis, that shows an increased airway resistance. The lung capacities that will be increased will be those shown there. And a restrictive disease will be reduced total lung capacity due to disease like tuberculosis or exposure to environmental agents like fibrosis. Pulmonary function tests can measure also the rate of gas movement with forced vital capacity, which is the amount of gas forcibly expelled, forced expiratory volume, which is the amount of gas expelled during specific time interval. And this is a common measurement that we often take, the amount of air expelled in the first second. So healthy individuals can expel about 80% of forced vital capacity in the first seconds, and patients with an obstructive disease will exhale less than 80% in the first seconds, whereas those with a restrictive disease will exhale 80% or more with reduced forced vital capacity. The minute ventilation is the total amount of gas that flows into or out of the respiratory tract in 1 minute, and the alveolar ventilation rate is the flow of gases into and out of the alveoli during a particular time. And again, these are all important measurements to try to help doctors, medical professionals see what could be wrong in the lungs. And especially with COVID, respiratory technicians were in need to try to measure kind of how the lungs are functioning. So these respiratory volumes were used a lot to measure the respiratory volumes of the lungs. Alveolar ventilation then takes into account the amount of dead space, tidal volume, and the rate of breathing. It can be calculated as follows. And again, I normally will not show or give you a lot of formula type questions. Because dead space in an individual is normally constant, alveolar ventilation is affected by tidal volume and frequency. So significant increases in alveolar ventilation are brought about by increasing your tidal volume rather than frequency. So rapid, shallow breathing can actually decrease the alveolar ventilation. So this is just a good review chart on the effects of breathing rate and depth on alveolar ventilation of 3 hypothetical patients. Gas exchange then, we'll talk a little bit about gas exchange here, and especially in the third part of this chapter. Gas exchange then occurs between the lungs and blood, as well as blood and tissues. External respiration has to do with the diffusion of gases between the blood and lungs. Internal respiration has to do with the diffusion of gases between blood and tissues. And both processes are subject to basic properties of gases and the compositions of the alveolar gas. Dalton's law of partial pressure takes into account the total pressure exerted by mixing gases, and that is equal to the sum of pressures exerted by each gas. And when we say partial pressure, that means the pressure exerted by each gas in a mixture, and it will be directly proportional to its percentage in the mixture. So for example, if total atmospheric pressure is equal to 760 millimeters of mercury, nitrogen makes up about 78.6% of the air. So therefore, the partial pressure of nitrogen, we take the percentage, 0.786, and multiply it by atmospheric pressure. So in partial pressure, we get about 597 millimeters of mercury due to nitrogen. Oxygen makes up about 20.9% of the air. So its partial pressure of oxygen is equal to about 0.2% of that, 159. So the air is actually mostly nitrogen. Air also contains about 0.04% of carbon dioxide, 0.5% water vapor, and other insignificant amounts of other gases. But at high altitudes, the partial pressures will decline, and at lower altitudes underwater, the partial pressures increase significantly. So here's a comparison of gas partial pressures and their approximate percentages in the atmosphere and in the alveoli. And you can see here the atmosphere at sea level, and then the approximate percentage of each gas in the alveoli. And you can see again how nitrogen makes up the most of our partial pressure in the air. Henry's law explains for gas mixtures to be in contact with liquids, each gas will dissolve in the liquid in proportion to its partial pressure. At equilibrium, partial pressures in the two phases will be equal, and the amount of each gas dissolved depends on its solubility. So carbon dioxide is about 20 times more soluble in water than oxygen, and very little nitrogen will dissolve, and also temperature. As the temperature of the liquid rises, solubility decreases. And an example of Henry's laws are hyperbaric chambers. So someone can go into a hyperbaric chamber and get an increased level of partial pressure of a gas. So a homeostatic imbalance. So for example, breathing oxygen gas at 2 atmospheres is not a problem for short periods. However, oxygen toxicity can develop rapidly if the partial pressure of oxygen is greater than 2.5 to 3 atmospheres. So an excessively high oxygen concentration can generate huge amounts of harmful free radicals, and this can result in a central nervous system disturbance in the brain and spinal cord, so this could cause coma or even death. Alveoli contain more carbon dioxide and water vapor than atmospheric air because of the gas exchange in the lungs. So oxygen always diffuses out of the lungs and carbon dioxide diffuses into the lungs. Humidification of air by conducting passageways and mixing of alveolar gas with each breath, which means newly inspired air mixes with air that was left in the passageways between breaths. External respiration that has to do with pulmonary gas exchange. This involves the exchange of oxygen and carbon dioxide across the respiratory membranes. Exchange is influenced by partial pressure gradients, gas solubilities, the thickness and surface area of the respiratory membrane, and ventilation perfusion coupling, which is matching of the alveolar ventilation with the pulmonary blood perfusion. The partial pressure gradients and gas solubilities, these are steep partial pressure gradients for oxygen that exists between the blood and the lungs. So venous blood has a partial pressure of oxygen of about 40, alveolar of about 40, which drives the oxygen flow into the blood. So there's a lot of words here on the screen, but I just want you to know, because of the partial pressure gradients differences, blood will always be driven from oxygen into alveolar blood and from venous blood back into the lungs. Partial pressure for the gradient for carbon dioxide is less steep. So the gradient, even though the gradient is not as steep, carbon dioxide will still diffuse in equal amounts with oxygen. This is the reason that carbon dioxide is 20 times more soluble in the plasma and alveolar fluid than oxygen. So what I just want you guys to focus on here is basically these partial pressure gradients promote gas movements in the body. So in the lungs, for example, oxygen is driven from the air in the lungs into the arteries that will take that oxygenated blood to the heart. And the partial pressure of carbon dioxide is driven out of the capillaries into the lungs so it can be exhaled from the body. So these partial pressure gradients are just important for promoting gas movements in the body. This shows the oxygenation of blood in the pulmonary capillaries at rest. So from the start of the capillary and from the time in the capillary, it just shows that oxygen will travel into those capillaries in the lungs to be taken to the heart, and carbon dioxide will be exhaled. Also, the thickness and surface area of respiratory membrane, the respiratory membranes are very thin. So the large total surface area of the alveoli is about 40 times the surface area of the skin. And this just helps to promote gas exchange as well. Another homeostatic imbalance that we'll talk about is the effective thickness of the respiratory membrane increases dramatically if the lungs become waterlogged and edematous, which means swollen. And this is seen in pneumonia or left heart failure. The 0.75 seconds that red blood cells spend in transit through the pulmonary capillaries may not be enough for adequate gas exchange. So the result is your body tissues will suffer from oxygen deprivation. Certain pulmonary diseases also drastically reduce the alveolar surface area. So for example, in emphysema, the walls of the adjacent alveoli will break down and alveolar chambers can enlarge, or a tumor, mucus, or other inflammatory material can also reduce surface tension area, which can block the gas flow into the alveoli. And this just shows the lung with emphysema, which contains tumors, mucus, and inflammatory material. It has much larger alveolar chambers than the normal lung. So these are just the tissue changes in emphysema. External respiration, a little more about ventilation, perfusion, coupling. The word perfusion has to do with blood flow reaching the alveoli. Ventilation is the amount of gas reaching the alveoli, and ventilation and perfusion rates must be matched for optimal, efficient gas exchange. Both are controlled by autoregulatory mechanisms. So the partial pressure of oxygen controls the perfusion by changing the arterial diameter, and the partial pressure of carbon dioxide controls the ventilation by changing the bronchial diameter. More influences on local pressure, partial pressure of oxygen. This just shows how the changes in partial pressure of oxygen in the alveoli can cause changes in the diameters of the arterioles. Changes in the partial pressure of carbon dioxide can also cause changes in the diameters of the bronchioles. Balancing then ventilation and perfusion just involves changing the diameters of the arterioles and bronchioles. This ventilation perfusion is never completely balanced because regional variations may be present and occasionally alveolar ducts may be plugged with mucus. So this just shows how the ventilation perfusion coupling, if ventilation is less than perfusion, we might get a mismatched, or ventilation greater than perfusion, we might also get kind of a mismatch between the ventilation and perfusion. Internal respiration then involves capillary gas exchange in body tissues, where partial pressures and diffusion gradients are reversed. compared to external respiration. And I'll kind of end here again with this picture showing how partial pressure gradients promoting gas exchange in the body are extremely important to kind of increase greatly the partial pressure differences so that, again, oxygen can always be diffused into the arteries from the lungs and carbon dioxide can always be diffused out of the lungs. So we'll stop here with this PowerPoint and I'll do part C, excuse me, with a next recording. But thank you for listening and we'll see you for the next recording for